You're listening to Medscape's In Discussion series on Cardiorenal Metabolic Syndrome, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Nihar Desai. Dr. Desai is an associate professor of medicine and vice chief of the section of cardiovascular medicine at Yale University School of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello and welcome. I'm Dr. Nihar Desai from the Yale School of Medicine. Delighted to welcome you to Season 1 of the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast series. Today we're discussing the cardiorenal metabolic syndrome. We're going to define it, get into the staging system, and get into some of the high-level therapies that folks are very, very interested and excited about. I'm delighted to have as our guest today, Dr. Chiadi Ndumele. Dr. Ndumele is an associate professor in the Department of Medicine at Johns Hopkins University. His research focuses on the relationship between obesity and cardiovascular disease, particularly in the heart failure context. So Chiadi, welcome to the Medscape In Discussion podcast. We're absolutely delighted to have you.
It's good to see you. Good to talk to you.
So Chiadi, I think we want to cover a lot of topics with you, and you're really going to help kind of set the stage for this entire series in this opening podcast discussion. I thought maybe in that spirit, we would just start from the beginning, if you will. Maybe give us your sense of how do we define this? What is cardiorenal metabolic syndrome or cardiovascular kidney metabolic syndrome? And then obviously we'll get into some of the other elements of that, but maybe just start us off with some of the backdrop.
I think this is a pretty major focus area, I think, for all of us now, because cardiovascular renal or cardiovascular kidney metabolic health really impacts pretty much every organ system, and it's a major challenge. And as we'll talk about, its prevalence is quite substantial in our population. But I think the reason why we're talking about it so much right now is really for a few key reasons. Number one, we know that there's such a close interplay among metabolic risk factors, things like obesity and diabetes, with chronic kidney disease and the cardiovascular system. And it's a multi-directional interplay between those, but they're closely linked. We can't think of them as separate entities. And then I think over the last few decades, what's really happened is that we've seen a shift in the phenotype of risk in the population, where we're really seeing this increasing burden of obesity, diabetes, and chronic kidney disease. And that's really becoming increasingly the predominant phenotype of risk. And we're also seeing earlier and earlier presentations with cardiovascular disease, such that this is something that's becoming a challenge for middle age and even younger adults. The consequence of CKM syndrome particularly is premature mortality. Lots of years of life lost for the individual components, and even more so when we consider them together, synergistic increases in mortality. And I think one other real major challenge is it really contributes substantially to disparities in the population. That's kind of, I think, the impetus for why this is such a major issue to be addressing. At the same time, the best thing that's going on now is we have a much better scientific understanding of this interplay between these systems, and we also have lots of exciting new therapies that can favorably impact metabolic kidney and cardiovascular outcomes. So I think that's really the impetus that sets the stage. I think to your point, we really need to talk about what is it? How do people recognize and how can we actually define cardiovascular kidney metabolic syndrome or cardiorenal metabolic syndrome in the population?
Yeah, Chiadi, thanks so much. And I think, all of us who are clinically active, and I'm sure for the audience as well, we've seen this. We've seen this in front of our eyes happening, the conditions that our patients have and the overlap and the interplay of all of those. I think it was so elegantly captured. I'm sure what was a very lengthy process, but I know that you led a very important scientific statement on behalf of the American Heart Association on cardiovascular kidney metabolic syndrome. So maybe take us inside that document, give us a little sense of what is the definition of cardiovascular kidney metabolic syndrome? How do we think about it? And maybe take us a little bit inside the document as well.
The AHA brought together a multidisciplinary group of clinicians and scientists, not just cardiologists like us, but also nephrologists and endocrinologists and primary care physicians, and then also adult and pediatric physicians, as well as individuals who are not clinicians but had some important scientific insight, really to kind of provide that multidisciplinary and multi-system perspective for this issue. I should also just say, one of the other big things is that we've seen a shift in the last decade in our cardiovascular mortality trends. So we've had favorable improvements in cardiovascular mortality for about 5 decades: smoking cessation, better blood pressure and cholesterol control, better kind of procedural options for people with acute cardiac coronary syndromes. But now in the last decade, we've seen a plateau and is starting to see an uptick. And that really seems to be related to this increasing burden of these conditions. So that was really, I think, really what set the AHA on fire in terms of making this a key focus. One of the first things, to your point, was to define CKM. To define CKM syndrome, there's a lot of discussion, but at the end of the day, we really kind of simply define it as a health disorder that is due to connections among heart disease, kidney disease, diabetes, and obesity that leads to poor health outcomes. But one of the things that we wanted to clarify was that CKM syndrome includes both individuals who are at risk for cardiovascular disease as a result of metabolic risk factors and chronic kidney disease, or the combination, and those who have existing cardiovascular disease where those factors are there, could be related to having cardiovascular disease, or they could be complications of cardiovascular disease, but they impact prognosis and impact approaches to care. That really then defines CKM syndrome across a spectrum that is then reflected in our staging that came next.
Yeah, Chiadi, thanks so much. And I think that's the perfect segue to the next part that I really want to get your sense for is, it's such a big and broad topic and obviously across multiple organ systems. And as you said, virtually every part of the body pathophysiologically is affected. I think one of the important elements of the document, what's really critical for the audience, is that there was a staging system that was introduced in the document to begin to help us talk about these patients and to really think deep about how do we categorize them and what does that mean in terms of pathobiology to clinical care and ultimately to treatment and to interventions. And so maybe take us through some of that. What is the staging system? How does it work? And what's relevant for the clinician that's taking care of patients every day?
That's our primary focus, to make this helpful for patients and to make this helpful for providers. As we're thinking about this is complex. There is a lot here, but the reality is that's what patients see. It's often the case that we think about this from our individual silos, but patients are the ones who are seeing this confluence or cluster of interrelated conditions. So we wanted to make sure we're reflecting that reality. First, let me just say what the rationale was for the staging. So the staging rationale was really to basically provide a staging construct that reflected the progressive pathophysiology that's usually common to CKM syndrome. Most of the time, the major driver that's often unaddressed is excess and or dysfunctional adipose tissue. And that's kind of what's upstream of the development of most of the metabolic risk factors: diabetes, high blood pressure, dyslipidemias, and then also chronic kidney disease that are closely related to that and metabolic risk factors. And then that leads to the development of early subclinical changes in the cardiac tissue. And then finally, of course, for full on clinical disease. So we wanted to reflect that pathophysiology with a focus on life course prevention. So each of those stages really represents a window for preventive intervention to basically prevent progression to those later CKM stages. One of the key things in CKM syndrome as well is under-recognized clinical conditions. So, for example, in CKD, 90% of individuals with chronic kidney disease are unaware of that condition. So we really wanted to shed light and have more identification and start to address earlier these factors. And then also, when we're thinking about the allocation of therapies, as we go up in the stages, they also reflect not just later progression, but greater absolute risk. And as you know, that's where when we have greater absolute risk, we're going to think about intensified therapies because we're going to get a better number needed to treat. We're going to get more bang for our buck in those higher risk cases. So that's one of the things that's really reflected in the staging as well. And then finally, there's the concept of CKM stage regression that we could basically, by identifying people in these stages, stage 3 with early cardiac changes of the myocardium, or stage 2, that with weight loss and substantial lifestyle change, we can actually regress in CKM stages. There's 5 stages. So it starts with stage 0, which is primordial prevention, no risk factors, just trying to stop risk from happening in the first place at all. Stage 1 is excess and or dysfunctional adipose tissue, which, as I've mentioned, is the precursor to most of CKM syndrome. Stage 2 is metabolic risk factors such as hypertension, diabetes, hypertriglyceridemia, the broader concept of metabolic syndrome, and moderate to high risk CKD as defined by the KDIGO heat map that brings together EGFR and urine albumin to creatinine ratio. Stage 3 is subclinical cardiovascular disease in CKM syndrome. That's subclinical ASCVD by CAC or CTA, and then also subclinical heart failure. But we also have there the risk equivalents of very high risk CKD, which is a really profound risk equivalent, and then also high predicted risk using the new Prevent Risk Calculator. And then stage 4 is individuals with clinical CVD in CKM syndrome. So that's clinical CVD overlapping with metabolic risk factors and or CKD. But the larger point here, again, is a focus on prevention across the life course. It's meant for both youth and for adults. Each of these stages are tied to screening. We have screening recommendations that largely adhere with a lot of the current guidelines, but bring them together in one place that really focus on earlier and more systematic identification of risk. They're tied to, in our algorithm, approaches to management as well.
Yeah, Chiadi, thanks for taking us through that. And I think one of the other important points is I think the staging system, as you described, it's sort of a descriptive, phenotyping of patients. And that's often how clinicians and patients, kind of think about things. I want to sort of marry that maybe with another concept of how do we take the staging system and then overlay prediction in terms of risk for events, risk for other conditions happening. And so as patients move, if you will, from stage 0 to 1 to 2, and ideally, as you said, maybe regress from 4 to 3 to 2, what does that mean in terms of prediction of risk? Or how do we think about this from a quantitative sense?
As we were embarking on this initiative, one of the things that became clear is that we would need an updated approach to risk prediction to really reflect these needs of the growing CKM syndrome population. There was a recent letter in JAMA that really underscored this, that CKM syndrome among US adults is present stages 1 to 4 in about 90% of the population. So this is really covering the vast majority of our population and really highlights why it's something that's so key to kind of update our approach to thinking about prediction, prevention, and management to reflect CKM syndrome. So the prior pooled cohort equation, was obviously very helpful. It's been a key part of our approach, but it has a focus mostly on ASCVD, which is a very important outcome, but we know that heart failure is a really important outcome that's on the rise as well, and that wasn't represented. It's also focused on 10-year risk, and that's really important, but we know particularly for younger adults, a longer term risk horizon is also helpful for describing risk. They may not have a high risk for a heart attack or heart failure in those next 10 years, but in 30 years with an adverse risk profile, they might. And there was also a really key focus on guiding statin use. So there was, older cohorts used where individuals weren't on statin therapy to kind of support that. Here, this is an updated approach. And it's important to emphasize that this quantitative approach here is complementary to the qualitative approach in the CKM staging. So first, I want to just say the big things that were updated with the prediction model. So first of all, it was developed in a very large and highly diverse and generalizable population. So it was developed in 3 million individuals and then separately validated in another 3 million individuals. So that's just to kind of put it into context, compared to about 30,000 for the pooled cohort equation. And it used real world populations, including EMRs and the cohorts as well, where we saw kind of comparable risk relationships. It focuses not just on ASCVD, but also on heart failure and the broader composite of total CVD that includes ASCVD and heart failure. So that's important to reflect the kind of outcomes in the CKM syndrome population. It also starts prediction earlier at age 30 as opposed to age 40. We're seeing more and more early presentations with CKM syndrome and CVD in the population, and provides estimates not just for 10 years, but also for a 30-year time span. and starts to include some of these markers of CKM syndrome: hemoglobin A1C, BMI, EGFR, and then urine albumin to creatinine ratio where indicated. And then finally, because we know that social determinants are such a key component of CKM syndrome, really strongly related to who's developing these factors, it includes a place-based measure of social disadvantage, social deprivation index in the model. And because the models actually were generally pretty accurate for the different race ethnic groups, we didn't have to use different models. So we basically removed race specific coefficients, and it's just one model that works for everybody in the population. Just to describe the complementary approach, so in stage 3, high predicted risk using prevent is a risk equivalent. So basically, having a prediction above 20%, we're kind of putting that as a risk equivalent. So that's how a lot of people in the population be identified. I think of that as like a high risk primary prevention population where we're really going to be thinking about the most intensive therapies. But then also in that stage 1 and stage 2, then seeing higher predicted risk in those individuals will help us kind of get a better sense of where we're going to get the greatest net benefit from some of these preventive therapies. And this is really a helpful tool because now we really need to think about how we're allocating some of these non-statin pharmacotherapies, these newer CKM therapies that impact multiple axes of risk in the population. So we're hopeful that this is something that will really help us in that regard.
Yeah, thanks so much, Chiadi. This has been a terrific discussion. So you've introduced this concept of cardiovascular kidney metabolic or cardiorenal metabolic syndrome. You've taken us inside the document, very important statement that came from the American Heart Association, and you took us through kind of the staging that was introduced in that document. So I want to sort of double click on one thing. You give us a sense of the
Mm.
prevalence of CKM. What do we know? What's happening both in the US and if you can comment even globally, what do we know about CKM or CRM syndrome amongst the population?
So it's a very, very big challenge. It's certainly a big challenge in the U.S. and it's also global. So it's being driven by the fact that we have historic rates of obesity and diabetes among adults and also among youth as well. The estimates now are that 90% of the U.S. adults falls somewhere along the spectrum from CKM syndrome one through stages 1 to 4. So a very large portion of the population. We're seeing this all across the world. We're seeing a lot of it in Asia, particularly in South Asia, where it's such a profound relationship with CKM syndrome that we actually describe it as one of the risk enhancing factors for the likelihood of progression along the CKM syndrome spectrum. We're also seeing it in the Middle East in large quantities as well. But it's all over the world. It's really a global challenge. And the reason that this staging focus and even the screening focus, but the screening we actually adhere we align with the AAP guidelines, the Pediatric Association's guidelines for screening, is really just because this is not just an adult problem. This is a problem that starts in youth, and actually by the time we wait to adulthood, it's often the case that we have a lot of risk factors that are already kind of ingrained and that track over time and only become worse. So we run and think about this across the life course.
And it really seems like it is the tidal wave that we're all going to have to confront and manage together as kind of a community. And it's not just US, it's global, as you said. It's not just in adults, but it's really across the continuum of age. And I think we do have to have that mindset and a sense of urgency about how we're going to come together and reverse some of the trends and things that you have, so eloquently discussed here. I guess to that point, maybe give us your wide angle lens on why are we seeing this? I mean, why are we seeing a prevalence of 90%? You alluded to it. Again, it's surely obesity and some of what we're seeing in terms of metabolic risk factors, but maybe even take a step back. How do we think about social determinants? How do we think about inequities? How do we think about things that fall maybe outside of traditional clinical care settings, but we know have a very important relationship when it comes to cardiovascular, kidney, and metabolic or CRM conditions? So maybe give us a little wide angle lens on why are we seeing a prevalence of
Yeah.
90% and global and across the age continuum?
Yeah, so it's definitely a systemic challenge. I mean, obesity and diabetes really, frankly, can be kind of viewed within a broader kind of socio-ecological framework. So we can think about this from the standpoint of multi-level kind of factors at the societal level, everything, how we commute, how we're educated, how our healthcare systems are set up, then the community level, at the interpersonal level. All of these things are directly impact our health behaviors. We haven't changed genetically as a population in the last couple decades, but whatever our genetic or biological predisposition is nested within these multi-level social determinants of health. So we do see an excess burden of this in individuals with more adverse social determinants of health. And it really impacts everything from the development of these factors to the likelihood of them being identified, complications, and then certainly the final adverse cardiovascular mortality outcomes. So we actually really put social determinants of health front and center in the care model for CKM health, where we really want to have a focus on systematic screening for social determinants of health, really embedding this into our clinical workflow and our EHR, and then having individuals on our integrated healthcare teams that are addressing these social determinants and leveraging community resources and programs. I should also mention that one other major aspect that we see a lot in CKM syndrome is because of multi system dysfunction, we often see multiple subspecialists being involved, often very fragmented care. So we really want to focus on getting everybody on the same page, make it easier for patients to both have cohesive, patient-centered, holistic plans, and also to navigate the healthcare system. So we have a real big focus on interdisciplinary care models within the CKM syndrome approach, as well as a real mechanism for giving that holistic approach to patients. And then, of course, also thinking about thoughtfully applying these various CKM therapies like GLP-1 receptor agonists, SGLT2 inhibitors, finerenone, in addition to some of the older agents, and then also focusing on lifestyle in addition to pharmacotherapy. So these are all components of how we're going to be thinking about CKM care moving forward.
Yeah, thanks, Chiadi. And I think what a great prelude. We're actually going to have a dedicated session thinking about social determinants and how that overlays into this entire discussion about cardiovascular, kidney metabolic, or CRM conditions. And so I really appreciate you kind of setting the stage for that discussion. Let me switch gears a little bit because I know the document very nicely also provides a high level guidance around important pharmacological interventions. Yes, there's a lot that we can do in terms of lifestyle, and those are, of course, very, very important interventions. But maybe while we have you, we'll get your sense of where do you see the field in terms of pharmacotherapy and interventions for cardiovascular, kidney metabolic. Maybe just give us a very high level sense of where is the field now
Yeah.
and what are you most excited about in terms of the therapeutic?
Yeah, so it's hard not to be excited about the different therapeutic opportunities we have in front of us. I think the SGLT2 inhibitors have been amazing, not just because they have some modest metabolic effects, but certainly lower heart failure events in particular and overall cardiovascular mortality. But they've also had a striking impact on kidney protection, which seems to be directly then linked to improved cardiovascular outcomes. We also see the finerenone being a powerful agent in individuals with diabetes and CKD, and we're in now is being tested just in heart failure itself in the fine arts trial. So what's really been exciting is to see the expansion of these therapies to different indications over time. And then, of course, the GLP-1, the incretin analogs, GLP-1 receptor agonists, now the double Gs and the triple Gs, we're seeing a dramatic impact on weight, metabolic risk factors, major adverse cardiovascular events, cardiovascular mortality. And then most recently, the FLOW trial was stopped early for evidence of benefit in terms of kidney outcomes as well. So that's all very exciting. The other big question, honestly, Nihar, is going to be, it's going to be easier in people with existing cardiovascular disease. And the SELECT trial gave us beautiful evidence for obesity and CVD. And apparently seems like that we're seeing effects even those people who didn't lose very much weight, which is fascinating. But the additional question is going to be, how do we allocate these therapies in those individuals who don't yet have CVD? How do we think about this in the prevention population? And then how do we think about combination therapies? There's been a lot of really interesting analyses about thinking about putting these together and seeing better benefit, but where do we do that? Is it in those higher risk populations where we're going to see more absolute risk reduction? So there's a lot of questions there. And I want to just say as one other piece, we're going to be wrestling with a lot of this over the next several years as part of an implementation strategy for the American Heart Association. So there's going to be a large implementation project where we're going to be really be thinking about these issues. And some of the big things on the horizon are both refining those SDOH approaches and also interdisciplinary approaches, but access to pharmacotherapies. That's a big issue that all of us are going to be having to contend with, especially for these GLP-1 receptor agonists, how we're addressing obesity in the population, how we're thinking about educating in CKM, and then finally thinking about real world strategies for implementation. So these are going to be some of the things that we're going to be addressing for the next several years, but I think it's going to have a really big implications for population cardiovascular health.
Wow, how terrific, Chiadi. So, lots of exciting and important work ahead, and glad that you're having a chance to lead those efforts and to play a very important role in that implementation program. Obviously, today we've covered so many topics. We really kind of covered, CRM or CKM, the staging system, how that interplays with prediction. I think Chiadi, you did an amazing job also talking to us about SDOH, that sort of wide angle lens, what's going on in terms of trends, and then also what excites you. And so, with this big challenge that we have to confront and face, come an era of transformative therapies that I think can be brought to patients and to the communities that we serve. And so a really wonderful and exciting discussion. I really appreciate you kind of taking us through that. Thank you again, Chiadi, so much for that. I will also just say to the audience, please take a moment to download the Medscape app to listen and subscribe to this podcast series. Thank you again so much for joining us. This is Nihar Desai for the Medscape In Discussion Cardiorenal Metabolic Syndrome podcast.
Thanks for listening to Medscape's In Discussion Cardiorenal Metabolic Syndrome podcast series with our host, Dr. Nihar Desai. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cardiorenal metabolic syndrome.